Welcome to Nipped Toxxed. I'm Dr. Ashley Robey and I have with me Crystal Stutler, Nurse Practitioner Crystal.
Hi, nice to meet you guys.
Thanks for coming on. And today we're going to be talking about hormone replacement therapy and the recent removal of the black box warning that the FDA had previously placed on that. Crystal, can you first tell our listeners or viewers what exactly a black box warning is?
A black box warning just carries high significant adverse life-threatening risks. So there's been strong evidence that there are severe risks, and typically that's when it's labeled a black box.
So if you see that on any of your prescriptions or medications, it's definitely a sign to you as the patient and a sign to your provider that, hey, take a second look, think twice before you're just routinely prescribing it. Starting with the Women's Health Initiative in 2002. This was a study that looked at a group of patients and was really the impetus behind why the FDA came up with this black box warning. So what's changed? Why have things all of a sudden made a 180 where before it was thought to be a bad medication with high risk, and now everything's cool? What's going on?
Yeah, so I think the biggest change is that study was actually inconclusive. They actually stopped that study early because of the risk factors that it brought on, which was increased breast cancer and cardiovascular events. So the study was inconclusive. Number two, the age range on what the study participants in that study. I think the average age was 63, which those individuals are already at high risk for cardiovascular events versus a woman who's entering her 40s and potentially early 50s. So I think age range plays a huge part in this.
So they picked kind of the non-classic patient group. Tell us more about the actual hormones that were included in this study.
Yeah, so the hormones that they used in this study were actually synthetic. The hormones that we are currently using in hormone replacement is bioidentical.
So yeah, they're manufactured. They're not the same as what's in your body.
Correct.
And for example, the
Estrogen.
they're obtained from the urine of pregnant horses. So certainly that's not a chemical that is innate to the human body. That's a pregnant horse chemical. And so you can't expect it to have the same kind of effects on a human as it would on a horse. So that's why you're seeing the different outcomes. Another challenge, and we'll get into this later too, was the route of administration. A lot of the medications that were administered in that particular study were oral. And there's a big difference with regards to the potential side effects, but also the chemical breakdown products of the various medications that you take. So when you take a medication orally, for example, either estrogen or testosterone, the breakdown products via that route are much different than the breakdown products when it's either transdermal or subcutaneous, and that can be really impactful too. So those are all things that were, I think, potential flaws in that Women's Health Initiative study that really led to some skewed results, and really also led to essentially a huge part of our population no longer feeling like they are good candidates, or having their providers also feel like they are not good candidates for this medication because of the high risk profile. Essentially, they were suggesting that the cardiovascular complications from taking hormone replacement therapy were just too great to accept any of the benefits from that therapy. And essentially, upon further review of not only that study, but additional data points and studies, the FDA has revoked that black box warning and saying, okay, it's good.
The benefits outweigh the risks, for sure.
So one other point is that fewer than 5% of postmenopausal women take hormone replacement therapy, and that is between 50 to 70 million women who have essentially been denied or discouraged from taking hormone replacement therapy. And so I think that it's a pretty big change for women entering that phase of life, and I think it's important for us to kind of discuss what are the benefits, but what are the other things that a patient needs to consider in addition to the fact that, okay, now it's available. Like, what other things do you need to think of to kind of minimize your risk factors as well?
Yeah, so typically we want to make sure, obviously, you're not pregnant or breastfeeding. We also want to make sure that you don't already have a predisposed cardiovascular history. And then the biggest one I would say would be breast cancer. You can safely get hormones with breast cancer, but it is something that we definitely have to pay more attention to. Is your breast cancer hormone derived? That's the biggest question that we want to ask.
It seems like, at least from my experience, that most oncologists say not for 5 years.
Correct.
And then it's still kind of on a case-by-case basis.
Right.
So it doesn't automatically mean that you are not a candidate for hormone replacement therapy, but definitely something that you would want to have your providers be in agreement with before you went down that road. Because, you don't want to increase your risk just to have benefits. Speaking of benefits, why would a woman want to be on hormone replacement therapy? What can you get from that?
Yeah, so there's actually a lot of benefits. I always like to tell my patients it's bone, breast, and brain protective.
Ooh.
So bone, it can help with osteoporosis. I've actually seen a few cases where patients have had osteoporosis. We initiated some hormone therapy, and we've seen a decrease in those markers. And the brain prevents against Alzheimer's and dementia. And then it is actually breast protective. The estrogen and progesterone both are really great additives to help protect against breast cancer.
Nice.
We can also get improvement with our hot flashes, our night sweats, improved sleep and mood for our females.
Some of the genitourinary symptoms.
So as we
dryness.
age, you get some vaginal atrophy, which can cause some urinary complications, UTIs, or just
leaking,
irritation in general. Yeah. So one of my favorites is actually applying estrogen with some DHEA, and that kind of helps with that vaginal atrophy and those symptoms that we see.
Yeah, we do some other treatments for that too, with the Morpheus.
The Morpheus. We've got
the Forma V.
Yep.
Those are also pretty good.
Yeah.
So sometimes and depending on where you are, but sometimes I think a multifactorial approach can be the best. But yeah, so the patients that have been previously told, essentially this just came out in November, that perhaps hormone replacement therapy wouldn't be ideal, are going to probably start really looking at this as a reasonable option. We kind of touched on the route of administration.
Yeah.
What are some of the most common routes that you use in your practice for, we can go through the main hormones, so the estrogen, the progesterones, the testosterones, and obviously there's others, but how do you like to prescribe those?
I personally, for my estrogen, I really love my pellet. Testosterone as well, because both of those are bioidentical. As we talked earlier, when we're taking things orally, you have that first pass effect on the liver, which can actually increase your clotting factors for DVT, pulmonary embolisms, increased strokes, etc. So I really, really, really like to veer from by mouth on those administrations. Now, our progesterone, the molecule is so big, it does have to be by mouth, unfortunately. It cannot fit into the pellet because the molecule is... Yeah, you can do topical too.
Yeah.
So progesterone is safe. You can micronized progesterone means bioidentical. That is safe to be taken by mouth. So I do prefer my progesterone by mouth, or you could do topical. And then back to the testosterone and estrogen. If you are not ready for a pellet, which some people aren't, you can also do creams or patches for those as well. And those are safe, bioidentical as well.
I see a lot of patients wearing the patches.
Yeah.
What are your thoughts about people just taking, because so many women also are on birth control pills, right? So essentially that is another oral estrogen. Again, oral progesterone, which we agree seems to be totally fine, but the oral estrogens on that have the same kind of potential risk factors that we're
talking about
issues
right now.
in this WHI study.
Yeah. 110%.
So, but that they're prescribed all the time.
Correct. I get a lot of patients that are actually in their 40s and 50s, and part of their menopause treatment is being prescribed birth control because it's giving a little bit of estrogen to kind of help ease their symptoms, which most of the time you don't get much relief with your birth control. But back to the first pass effect on the liver, you're actually increasing your risks of blood clots with birth control. And then you put smoking on top of that, and that doubles your risks of blood clots.
Yeah, and just back with the first pass, you get the metabolites or the breakdown products when you are metabolizing oral estrogen through your liver are actually pretty inflammatory. And that's in contrast to the metabolites of that estrogen product when it's either transdermal or in pellet form, subcutaneous. And so those oral estrogens just create lots of inflammation. And inflammation, of course, is bad. So inflammation leads to cardiovascular issues. It leads to inflammation in your brain is how you get dementia. Inflammation is making us age, which we don't like.
Oh, yeah, no.
So Anything that you can do lifestyle-wise to reduce inflammatory components is good.
Yes.
So eating healthy, avoiding things that are inflammatory, such as alcohol, cigarettes, not getting enough sleep.
Oh, yeah. That's probably
stress.
one of my big ones.
Yeah, those are all things that we have some control of. I mean, obviously we have genetic things that we can't really control, but we do control some of the environmental factors that we choose, and that can be really impactful as far as just overall quality of life and symptomatology.
Yeah.
So we both agree oral estrogen is not our favorite route of administration. How are you deciding whether you're guiding the patient toward a pellet form, a patch form, a topical cream form for those estrogens? What's the deciding factor or factors?
Yeah, of course. So, I mean, number one, we talked about earlier, if we've got some vaginal atrophy or some urinary issues, of course, I'm going to prescribe a topical estrogen form.
So you can get it right where you need it, essentially?
Correct, absolutely.
So in this case, the patients are applying it intravaginally?
Yes.
Okay.
Yes. So that's kind of when I would do the topical. I will say, as far as lab values go, topical versus pellet, you're going to get a superior lab value from a pellet versus a topical. Topical, it's kind of hard to know how one person absorbs it versus another, so your lab values can actually change a little bit. I will definitely go topical route for someone who's not ready for a pellet, and at least kind of ease them into it. If their symptoms are improved with the topical, then we stick with the topical. If we're still seeking for something a little bit further, then that's when we kind of have a discussion about switching over to the pellet.
Okay. And then women taking testosterone.
Yeah.
Is that pretty common in your experience?
Absolutely. So I think there's been a miscommunication that testosterone is for males. Yes, they carry a significantly higher value of testosterone, but as a female, we actually have a small amount of testosterone in our bodies as well. Funny enough, men have a small amount of estrogen in them as well, and you would think that that's a female hormone. So they kind of
balance.
There's definitely a happy balance here. So for the testosterone, someone who comes to me who is wanting to try to improve their libido or just their stamina, motivation, we've done everything as far as correcting their B12, their vitamin D, and their iron, and they're still complaining of fatigue, I might actually start talking to you about some testosterone. That's a way to just kind of help optimize how you're feeling and really address the libido as we age. That's just something that kind of declines, and testosterone is a great option for that.
Now, do you see many patients in your practice that are placed on supra-therapeutic doses of testosterone, both as women and men?
Absolutely. So I definitely have gotten some patients who came to me and want me to take over their hormone therapy, and they've got the side effects, the increased acne, the hair growth, etc.
Their voice is like this.
Deep in voice. I have seen it a time or two. I will say that I feel like I've been doing this for about 6 or 7 years now, and I'm definitely more conservative with my testosterone dosage and where I want that level at. There's some women that like it in the 300s. I don't really think that you need to get that high. I think that
it's approaching like a male dose.
That's high.
Dose,
You're definitely going to have some side effects from that: the increased hair growth, the deepened voice, the acne, water weight, etc. I really, really try to be conservative with my dose so we don't get those symptoms. So you can still feel the benefits of the testosterone, but we don't need to get that high.
Mm-hmm. Same thing for men. I mean, I think that it's not always more is better.
No,
right?
no. Honestly, you can have a negative effect. You can have symptoms of low testosterone with your testosterone being too high. Mm-hmm. So we definitely got to keep an eye on where those levels are at and how you're feeling.
I know we're getting a little bit off track, but for testosterone too, for men, it's important that you discuss with your patients that taking exogenous, meaning not part of your body, coming from outside, testosterone can suppress the natural sperm formation. Yep. And so especially younger men or men that think that there's a chance that they may want to have additional progeny, kids, you have to take that into consideration. And oftentimes you'll talk about other medications as a first-line treatment to try to boost testosterone levels, as opposed to that just right off.
If you are on testosterone therapy, it takes a good 6 months to get your sperm count back, and it's not even guaranteed you're going to fully get that back.
Yeah.
So definitely take that into consideration.
Yeah, I think we've come across that, unfortunately. But yeah, so I think that it goes to making sure that you have a provider that, I don't know, is aware of all those things. I know there's a lot of online options now. And I've messed around with that a little bit. And it's more of, at least from my experience, is more of their approach is you as the client or the patient are telling them what you want. And then it's essentially like, do they agree or not? And it usually seems like they're cool with the most stuff.
Yeah, that, and I've actually seen where they're not even checking labs. They'll initiate testosterone or whatever hormones they decide, and it'll be 9 months down the road, and that's when I kind of get them. And I'm like, where's your labs at? And well, they don't even know.
Yeah. So at some point it becomes malpractice. Yeah. Especially for some patients where you can have some irreversible outcomes. But I think that on one hand, I get that patients, they think they know what they want. There are options to get that really fast and delivered to your door with like a couple minute phone call, or not even a phone call. It can just be like typing in some answers in text, like, I've got this or that. And then you will literally get your medication, where in some instances that can be great, but I think that there are situations where that can be really problematic. And if you don't have someone who's doing a really comprehensive review, not just about this one particular point in your health that you are interested in, because, you know, our body is a system of systems, and you can't just look at one little part of a system and tweak that and not think that other parts are contributing, or tweaking that is going to affect other parts. So having someone like Crystal who is really thorough and is making sure that, hey, I'm not just going to make sure that your testosterone level is exactly where you want it. Like, I'm going to look at you holistically.
Yeah, your thyroid, that's a big one. Vitamin levels, you know, your cholesterol panel. We kind of look at it all, and we're looking at everything at least once a year. And then in between there, we're getting your hormones for a female every 3 months, and for a male every 3 to 6 months. So it's a continuously looking at your labs.
Yeah, I think that's super important, and I think it's just overlooked a lot. Considering that not every patient who's watching this video may have the opportunity to be a patient of yours, let's just kind of highlight some things that a patient should take into consideration, and certainly hope that their provider is also taking into consideration, like essentially best practices.
Yeah.
And so when we were talking about achieving certain hormone levels, a common paradigm that I've heard is like, start low on your doses, try to get optimized symptom control. And that means not only from optimizing all your positive symptoms, but minimizing the negative ones too.
Absolutely.
And not specifically focusing on an exact lab value. I mean, you want it to be, I think, in a
within range,
a normal range.
Yeah.
And that is a big difference too for you, in that traditional Western medicine, at least like from my training in medical school, was okay, and even from lab reports, where you get your lab report, and let's say your lab value for something is 10, and it'll say the normal range is 0 to 30, so you're good. But perhaps the optimal range is really 20 to 25, where that's where your body's really working the best. That's where you're kind of getting all of the benefits, but having minimal side effects. But if you get the 10, well, good, you're normal, and see you later. And I think that's one thing that you do differently, in that we're really kind of honing in on what is an optimal level as opposed to just an acceptable level for each individual person. And so that comes into play too with regards to lab results.
Yeah. We always say treat the symptom, not the lab value.
Okay, so for patients that have that higher cardiovascular risk, they have a history of potential heart issues or thromboembolic events, such as like clots in the legs or pulmonary embolism. Do you have thoughts about their estrogen route of administration?
Oh, of course. Whenever we have those increased cardiovascular risks, we definitely want to make sure that we're doing either the transdermal or patches or topical to minimize those cardiovascular risks. It's just safer. We might grab your labs a little bit more often just to make sure, like to see where your ranges are in your symptoms, but it just makes more sense to decrease that cardiovascular risk.
And what do you, speaking of, because I see this a lot too, and I kind of have to, it's mood dependent whether or not I say something, honestly. When patients come in and they're on birth control or oral estrogens, I find myself usually providing commentary, but what's your approach to that?
I think it's a gray area. I will definitely educate them and let them know, like, hey, you are taking synthetic form of hormones. Try to explain to them the risks, the cardiovascular risks. A lot of patients they fear, like, even in their 40s, like, well, what if I get pregnant? And I'm like, at that point, we're looking at your labs. Like, I can determine with your FSH and kind of where you're at. It's not
from like a perimenopause perspective,
right? It's not guaranteed that you're not going to, but I think your benefits outweigh your risks.
Sure,
for sure. But yeah, I definitely educate, and I let them make the decision. I think it's important that the patient actually makes the decision. I can just give them the information.
And when you say benefits outweigh the risk, are you talking about from switching from orals to a different route?
Yeah,
okay.
Absolutely.
Yeah. Yeah, it's tough because on the other hand, it's like you're not their primary care provider, so you're not taking over all of their health issues. But patients, they're smart and they have access to a lot of information,
especially with ChatGPT on.
Yeah, and so I in general just kind of encourage them and empower them to, okay, well, maybe this is something that you haven't taken into consideration or even really thought about. Like, just think about it.
Yeah.
Do your own little research. You have to take control of your own health.
Absolutely.
And so you have to be your best advocate. And so I think that is probably enough for most people.
I think it's really neat. We actually started a checklist here at Robey, and on that checklist, even someone that's coming in for talks, like, you don't even think about, like, no, I haven't been sleeping the greatest sleep recently, or I am feeling super fatigued now that I'm 42 years old, or whatever that might be. So it definitely opens up the discussion. Not just people who are seeking hormone replacement are candidates, but like anyone can be a candidate.
Sure.
So I think it's important to screen them.
Yeah, and that comes back to the whole normal versus optimal range, right? Because I think we probably start slipping outside of the optimal range earlier than you might think.
Yeah, I would say late 30s, early 40s, if I had to guess. And then technically, you're in perimenopause for 10 years before you go to menopause. So there's a long window there. Yeah,
so certainly lots of opportunities to explore where you are, fine-tune, try to keep your, we only got this one body here on this planet. Keep it functioning as best as you can for as long as you can.
Okay. So when we're talking about progesterone, I really like to do micronized progesterone from the compounding pharmacy. Reason being is it is bioidentical. It's made in a compounding pharmacy, so I know exactly what's going inside of there. Now, you can actually get micronized progesterone called Prometrium from your like Walgreens, CVS, etc., and it is considered micronized progesterone as well. I still really like the compounded version. If someone really insists on the pharmacy, I will do the Prometrium. But I just really like knowing that it's coming from a compounding pharmacy. I know what is going inside it, and it actually is made without the nut oil, the peanut oil, whereas the Prometrium from your Walgreens and CVS is actually made with peanut oil. So that is a big difference in that one.
Yeah, I think having less additives potentially is
absolutely
helpful.
Okay. So one of the questions that we have here is HRT safe if I'm 52 and just starting menopause? So my question to you would be, when was your last menstrual cycle? If you answer that your last menstrual cycle was less than 10 years, yes, you are good. Now, I will say that the sooner you start hormone replacement, the better off you are. But at 52, as long as you've not been without a cycle for at least less than 10 years, you are a candidate for hormone therapy safely.
The next question we had was patients asking about compounding pharmacies. And I don't know, I mean, I'm sure there's always like a kind of a debate between big pharma and mass-produced medications versus personally compounded medications. But essentially, I think as long as you are getting a bioidentical hormone, sure. I mean, I think you can talk about some of the other additives and the pros and often cons of those, and you know how to dose it appropriately. I'm not sure that it matters a lot.
I agree.
I mean, essentially people will do compounding. One of the reasons why you can get a compounded medication is because let's say you need a different concentration or you need a different medication added to that. That's how compounding pharmacies are able to get around some of the patents for pre-existing medications that you would get at your regular pharmacy, because that you need something different. If that's the route you're going, which we do that all the time, you just have to, just like everything, like you just have to read the prescription. It's not that confusing, but so you can't assume that it's the exact same concentration as a mass-produced product and that your dosing or a volume of dosing is the same. You just have to read the stuff. Like, I don't think that's particularly shocking or groundbreaking, but for some patients, if you're used to a certain way of dosing a medication, you do have to read the instructions.
Yeah, absolutely.
Yeah.
Next question was, how long should I stay on HRT? How long do you want to feel good? I mean, honestly, as long as we're monitoring your labs and you don't have any negative side effects, you can stay on this, honestly, indefinitely. I mean, my biggest question is how long do you want to feel good? I mean, most people don't want to
stop feeling good.
Yeah, so indefinitely is my answer.
And so tell me a little bit more about, since your primary routes of administration are either topical patch cream or the pellet, can you tell our viewers, listeners, a little bit about like the frequency of those routes?
Yeah, so if we're doing topically, you are, that's going to be applied daily.
So like a cream, you mean?
Right. So if we're doing testosterone daily cream, you're going to be applying that daily. Estrogen is a little bit different. In the beginning, you're going to be applying it daily just to kind of help with that lubrication. And then it's more as a as-needed basis. With our pellets, female pellets, we typically do every 3 months. It's really nice that you get to get pelleted and you forget about it for 3 months. Just book your next appointment and you don't have anything that you have to remind yourself about. Males, for their pellet, is every 5 to 6 months, depending on how you metabolize that. Same with the females. If you are a person who works out a lot or high stress person, anxious all the time, you might burn through your pellet a little bit quicker. But on average, females 3 to 4 months. On average, males 5 to 6 months.
And what about the patches?
Patches, you are applying that typically once a week. You apply a new patch once a week on the patches. So if anybody's curious, when we do our pellet treatments, everyone first question is, what does it feel like? I will say it's pretty painless. The worst part is the numbing medication. It is a poke and a burning sensation. Right after that, I do kind of rub the tissue so it kind of integrates the medication. If you can get through the poke and burn, you're fine. Everything after that is literally painless.
Less intense than a dental injection.
Yes, absolutely.
The mouth has such a higher density of nerve ending, so if you're in the kind of the buttock hip area,
it's a fatty area, which I think it's not
as sensitive, nowhere near. Less intense than even like a flu shot in your delt, which I think hurts. So yeah, compared to those, which I would say like a lot of people have experienced, having the numbing medication, and I agree, that's the worst part. Like compared to those, it's still not bad.
No, it's not bad at all. I really, honestly, after I do the procedure, most often the patient will tell me, is that it? And I'm like, yes.
And for you, you kind of mark out where you're going to put the incision so the
Yep.
patient can see it.
Yep.
They can make sure that, okay, that's going to be pretty well hidden in my
Yep.
underwear, bikini line, those kinds of things. So that even though it is a tiny little scar, that scar's in that hidden
Yep.
zone.
And I try to
garments.
stay around that same area just so you don't have a bunch of scars. So it's pretty contained.
Mm-hmm.
I always say, honestly, once it heals, it kind of looks like a cat scratch. Like, and that's nothing too much.
Or like
it's
a mole removal scar.
Yeah, it's
small.
It's very
like
minimal.
Smaller than a thumbnail.
Oh yeah, absolutely.
So it's small.
So after I numb, kind of massage the area a little bit, let that medication kind of integrate with the tissue. I do make a very small incision, probably less than half an inch. I insert what's called a trocar, yeah. And it's right above the muscle. So, and honestly, most times it slides in like butter. And then that allows me to actually put the pellets in, and that it pushes the pellets. So if your incision's here, your pellets are out here. It allows me to push those pellets in. I'm pulling the trocar out. I put a steri strip on over top of that, and then a piece of gauze and a Tegaderm. Tegaderm typically comes off in 24 hours. Steri strips will stay on for 3 days. I typically tell you no glute exercise, no large bodies of water, so no swimming pools, bathtubs, anything like that for 3 days. And then
you kind of bathtub as a large body of water.
Because if I don't say that, then someone will be like, well, can I go and get in the lake? Well, yeah, no, you can't.
I know, but like that's a small body of water, right? No soaking in any water.
Yes.
But you specifically say no large bodies of water.
Well, I don't know. I guess I've never.
Okay, but then what's a small body of water they're allowed to do?
I guess.
You can put your butt in a dishpan for Crystal. She's okay with that.
You can shower, but you cannot immerse your bottom in any water. There. Okay, we'll put it that way. And then for the males, that is extended a few extra days. So instead of 3 days, I actually tell you 5 to 7 days. No water. You can shower.
Why is that?
No. Infection. I want to make sure that.
No, I mean, like, why more for men?
Oh, we're putting way more pellets in that area. They tend to be more muscular, less fatty than a woman.
Yeah.
So they
higher risk of extrusion.
Yeah, they actually do have a higher risk of extrusion.
Yeah.
So that their time is extended by a few days.
Yeah, that's not that bad though. So Crystal, what are your thoughts on sublingual hormones?
Yeah, so if somebody is not really wanting the creams, because creams can be a little messy, unfortunately. But another option would actually be a troche underneath the tongue, and it dissolves. Now, because it's dissolving, it's actually bypassing the liver.
So you're not swallowing it?
Right. So we don't have to worry about the first pass liver increase.
I still feel some of it will be swallowed, right? Like you're still going to it's going to mix with your saliva. Some of it's going to dissolve. I feel like some of it's going to mix with your saliva, and you're constantly low-level swallowing saliva. So I would guess, yeah, I don't know. I
don't use them that often. I guess that's more just for a patient who's really not wanting creams, not ready for the pellet. That is an option. I really, really veer from IM injections on my females. It's considered synthetic, and I increase risk cardiovascular. Like, I really try to veer away from IM injections for my females.
I guess my thought on the sublingual is that it's a hybrid between a topical and oral. Like it's somewhere between. Cause I think you probably get a little bit of oral. Yeah. But yeah, so for the intramuscular, so you don't like that for.
I don't.
Estrogens.
I feel
but what do you think about testosterone?
I mean.
Do you have patients using that?
I have 2, and I think it's because they
did very little.
Yes, they were not ready for pellet therapy.
Sure.
They still wanted to try it. I did make sure I laid out all, it being synthetic. I laid out all of the risk factors for them, and they still wanted to proceed with the IM injections.
You can't get IM bioidentical in either estrogen or testosterone, correct? Well, the other challenge, which is really difficult for the IM, are the peaks and troughs, right? So ideally, not only do you want a bioidentical hormone, but you want a bioidentical dose. You want to match a normal level for you. And if you are injecting testosterone for example.
Once a week or twice a week.
You're going to get, right after the injection, it's going to spike really high, so the level's going to be really high, and then it's going to go lower. So the less number of injections, for example, of testosterone you do per week, so that means you're getting a bigger dose per injection, more milligrams, then the bigger those peaks and troughs. So some people will do it, if you do it twice a week, that you're going to take a smaller dose with each injection. And so the heights of the peaks and the depths of the troughs are less. And you could do it once a day, and you're it's like a sinusoidal wave where you're still having peaks and troughs, but it's not going to be as great as if you were doing it once a week. But all of those can be avoided with a sustained release medication. Yeah, that he had already alluded to, which is the pellet. Yeah. So it definitely shines in that regard. And it's in those peaks and troughs where the symptoms are the worst, where you have the really high levels or in the low levels where
just extreme fatigue, no motivation.
Right. So the less you can have of those, the less bad symptomatology, the less side effects, the better.
Yes.
So yeah, that's the downside of IM dosing.
Yeah, I agree.
And the fact that it's not bioidentical, of course. Right. But yeah. So it seems like losers are definitely orals. I would say that's my least favorite route, with the exception of oral progesterone. Definitely the pellets are great for the estrogens and the testosterones. I think the topicals are really good too, but it requires a lot more effort on behalf of the patient. You also probably have a little bit of peak and trough thing, because again, it is a daily dosing.
And you don't know how they're going to absorb it.
Yeah, exactly. The location of where you're placing it. You can also transfer it to people.
Yep. So I always tell them, if you've got small kids, animals, you need to make sure that you're applying it in an area that can be covered, and that you don't have like a small child sitting on your lap if you just put it on your inner thighs, etc., because you can transfer it to them.
Right. Some of it probably just gets right up absorbed right into your clothing. Yeah. You're losing that. And it probably depends on how long how moist is your skin, or how dry is your skin, how hydrated are you, how long did you wait before you put your clothes on. There's lots of variables in that route of administration. And again, like we were talking about before, the more of those from what the intended dose was to be to what you're getting, that's where you find yourself having less optimal results and potentially more side effects. And so I would say, even though it is very easy to do topical, it does have the downsides of those kind of things. So and then again, the sublingual, from my perspective, it's kind of a hybrid of either topical, which is okay, and oral, which pass now. I don't like it.
Yep. No, I agree.
So we don't do a lot of troche sublingual stuff.
I don't think I have anybody.
No, I haven't seen any. I haven't even seen a patient that happens to take it.
I haven't. Some of my other practices, very few patients request it. It's not a favorite, and I've even asked some of the pharmacists at Greenleaf and Pure Pharmacy, and they're not even really.
Oh, they're not even making them.
No, they make them. They're not jazzed about it. Yeah, they're not as.
We technically do have it.
Yes, but they're definitely, other routes are better for sure.
Yeah, no, that seems to be the consensus. So to wrap up, the FDA did remove the black box warning for hormone replacement therapy, and essentially that means that women in the perimenopausal and menopausal and postmenopausal time of their life, I think, are going to be less discouraged from replacing those hormones, and that for the vast majority of those patients, the benefits are going to far exceed the risks. And so that's pretty exciting. I think that's a big, that's huge for the realm of women's health. Yeah. And I know we were talking about men's hormone replacement too, but that was, again, the Women's Health Initiative was primarily focusing on those females. Yeah. You don't have to live with menopause symptoms. There's a way to live a more balanced life without those symptoms. And that's with hormone replacement. Yeah, which Crystal does. Nice. So thanks for everyone for tuning in. We will catch you next time. See ya.